partner at Sobel and Company, and I would like to welcome you to Sobel Insights. Sobel Insights is a weekly series to provide some brief information on various topics. Our goal today is to keep the sessions to 15 minutes. At this point, we do not offer CPE. If you have any ideas for topics or speakers, feel free to email me. You'll see my email address at the end of the session. And at this point, I'd like to jump in today's topic. Today's topic is healthcare valuation. Speaking with us today is Monica Kaden. She is the Director of Business Valuation. Good morning, Monica, or good day, Monica. I don't know what time people are viewing this. Healthcare valuation. We got very specific on this one, healthcare valuation. And we've done, and we're going to be doing a session on business valuation and asset valuation in and of itself. But how does healthcare valuation differ from traditional valuations?
Hi, Brad. Thanks so much for having me. Somebody who's doing healthcare valuation, I should first start by saying that the general approaches that we use to valuing a healthcare entity are the same that we would use in any business valuation. So income approach, where we're looking at normalized earnings of a company or forecasted earnings. We're going to look at the market approach, where we're looking at market comps and looking at multiples of transactions that have occurred and apply it to our company. And lastly, we're going to look at the balance sheet, the asset approach, where we're going to look at their hard assets, hard liabilities, and any intangibles. So those are the three primary approaches, and we will do that in healthcare valuation. But there are some nuances that make healthcare valuation different. For example, there are some very relevant laws. The Stark Law, which is a federal law, and the federal anti-kickback statute. And these have to deal with, well, the Stark Law is the physician self-referral law. So you have to be very cognizant if you're, let's say, valuing a practice and valuing, let's say, a surgery center that's connected to that practice. And how is that doctor referring to the surgery center? So you have to understand, because there are things that are legal, things that are illegal, and that has to be factored in also in how you're valuing these entities. So be cognizant of the Stark Law, federal anti-kickback statute, which talks about taking any kickbacks for referrals, and lastly, any state-specific laws. So knowing those laws is important. Also, a lot of healthcare valuation deals with compliance. So let's say there's an agreement between a doctor and a hospital that doctor is going to read MRIs for that hospital. He's a radiologist. There's an agreement between the hospital and the radiologist, and that agreement has to be at fair market value. So it's looking at agreements, and those agreements can be rental agreements, license agreements, management service agreements, all different types. And that's very important because there's oversight. There is government oversight, especially when you're dealing with larger organizations like a hospital.
I imagine within healthcare, it's different. So valuing a hospital is different than valuing a doctor practice, might be different than valuing an MRI practice, might be different than valuing a surgery center.
Absolutely. And one of the main things that would be different is revenue stream. And what is creating the revenues? So what creates the revenues to a physician practice is different than what creates the revenues to an ambulatory surgery center. The surgery center, basically a doctor's fee or a fee either is called what's called the technical fee, which is to the physician, or I should say the professional component goes to the physician, and the facility fee would go to the surgery center or to the hospital. So the revenue streams are different. So an employer also has to be aware. Let's say I'm valuing Dr. Jones's practice, and Dr. Jones also has a surgery center, and he gets paid. I have to make sure that let's say I'm looking at his comp, I only want to be looking at his professional component fees that he earns as a physician, not what's going to his surgery center as a facility fee, right? So we have to understand that. And just lastly, because I know we want to move on to some other things today, is we do have to look at physician compensation. That's an important part of healthcare valuation. We have certain databases where we do that. We have what's called MGMA, Medical Group Management Associates, where we look at physicians comp. Quite often, I do a lot of medical practices, and this is an issue, physician compensation.
Wow. So one of the things I know that everybody gets hung up on, and it should be a very easy concept, but I guess because I'm an accountant, I'm very used to it, is EBITDA, and how does that come into play as it relates to healthcare valuations?
Well, I think a lot of finance people know, and in the M&A world, that a lot of deals are done based on EBITDA. And right now, there's been a tremendous amount of consolidation and deals in healthcare. And a lot of these deals are based on multiples of EBITDA. I have a lot of doctors, urgent care center owners calling me, and they're all about the EBITDA. First, define it. If anybody doesn't know what it is, it's earnings before interest, taxes, depreciation, and amortization. And it is a proxy for cash flow. A lot of people look at EBITDA as a cash flow number. And in these private equity deals, what you have to think about, let's say a surgery center, no, let's say a large practice has 5 million in EBITDA, all right? And the doctors are each bringing home, let's say, several $100,000. Okay, well now when you forecast that EBITDA is going to be split between what the doctors take home, maybe if they stay as 49% owners, and 51% of that EBITDA is going to go to the investors. So that EBITDA is really the return that people are expecting going forward. And many deals are based on a multiple of EBITDA. And let's say, a surgery center, multi-specialty, very profitable, might go for 8 or 9 times EBITDA. Maybe if, let's say you have a surgery center that's selling minority interest to its physicians to buy in, so it's a minority interest, not control, you might value it 3 to 4 times EBITDA. So there are parameters, and as your EBITDA gets bigger, your multiple may get higher as well. There's high EBITDA.
Do you adjust EBITDA for particular events like a PPP or some particular event that would be non-recurring?
Absolutely. I mean, that would be done in any valuation where you'd want to normalize the earnings. And I think PPP is interesting because it can sit there temporarily as a liability. And as liability, PPP is a loan that finance a lot of companies. You see it as a loan, but in many instances, it's going to be a loan that's forgiven, and management's fairly confident it's going to be forgiven. And, an investor coming in or the sellers may really not want to consider that as a real liability. Sure. So it's always been a question, how do you treat that? For the most part, if management says, look, it's going to be forgiven, we're confident we can back this up, then I won't treat it as a liability. We'll show it, but we'll discuss it.
Okay. So now does Goodwill come into effect? I mean, I see it in a lot of business combinations, non-healthcare related. Is Goodwill as prevalent in healthcare valuations?
Goodwill, I would say Goodwill is very prevalent. In a way, it's something that a lot of healthcare entities don't want to discuss, because Goodwill, when Goodwill is paid for, it looks like it might be a payment for referrals. Let's say a hospital acquires a big practice, they're bringing it in, and they know they're not only getting the business of that practice, they're going to get all the business that practice is going to refer to the hospital. They're going to get MRIs, they're, all sorts of imaging, they're going to get, surgeries are going to be performed. They know when they bring that practice in, it's not only the cash flow of the practice, but now it's going to be these, what's called downstream referrals. That's really not what's supposed to happen. The hospital is not supposed to think about that. But of course they do.
Their business.
So, you know, and the government who funds Medicare and Medicaid, this is all government funding. The government is the one who cares about this. And so the government looks at this and they don't want to see payment for referrals. So that is why Goodwill is looked at in a different fashion than in other businesses, because it's payment for referrals, which are not allowed. The federal anti-kickback statute, Stark self-referral law, they don't allow this. However, you have private equity coming in. They see a fantastic surgery, surgery center. They love it. It's very profitable. They're going to pay significant goodwill for that practice. There's no way that surgery center, they'll never get it if they don't pay it. So they're going to pay a multiple of 8 times, 10 times. And when you figure out, well, how much is goodwill, you're going to see that, 90% purchase price is goodwill.
And I imagine they're buying it from the doctor, so there's no kickback situation there also?
No, there's no kickback.
Okay.
So
is that the biggest thing about private equity moving in? I mean, you hear that a lot. If private equity has a lot of money, they're throwing it around on the streets, and they're very careful. I'm not saying that they're willy-nilly, making it rain type of thing.
right.
But what is with private equity in the healthcare? How are they moving in? Is it towards the surgery centers mostly?
No, private equity, I would say private equity is everywhere. And there is huge consolidation, as most people know, in the healthcare industry. We see these big hospital systems. We see Atlantic Health. We see RWJ Barnabas. We see big systems. We're going to be down to like 2 systems in New Jersey, very soon.
Wow.
So there's a lot of consolidation, and there's a lot of roll-up. There's a lot of national roll-ups. You see, ophthalmology practices being rolled up, anesthesia practices being rolled up by national groups. So, and these are private equity groups. And basically the structure, which is like in any business, is private equity comes in, they want to find a big platform business. They want to find some add-on businesses, make it very efficient and get a very high return, and then sell it in 5 to 7 years and be out and make their money. There is a lot of private equity deals, but it's not necessarily always a good deal. And a lot of these deals, I think it's important to point out, is that, let's say physicians that maybe a big group is interested in their group, they have to look at the whole deal, not just the purchase price, which they get day one, but their ongoing compensation. Because in a lot of these deals, the compensation is reduced. So you can come to 5 years down the road and you're now at break even. It's as though the doctor was never bought out because he's taken a reduced compensation.
Right.
Many of these deals are structured that way. So it can be great if your time frame is, if you're a retiring doctor, your time frame is 2 years and you get most of your money, take reduced compensation for 2 years and you're out. But if you're a young doctor in a group, you're age 40, I call that young now, and you got your whole career to go, you don't want reduced compensation for the next 30 years you're working.
Right.
That is an unacceptable deal. So a lot of the hiccups in these deals, or you might have, a lot of partners. Like I had a deal where it was 50 anesthesiologists.
Wow.
Ranging, and they were a fantastic group. And they actually never sold. They were so efficient as they were, but they had a lot of potential buyers. But the issue was they had young anesthesiologists and older. And
Sure.
who won the deal? The older ones,
Sure.
not the younger ones. Who's more productive? Maybe a lot of the younger ones. So some of these deals don't happen. So there are lots of issues. The other thing with private equity, I think, is sometimes care can be compromised. So, they're looking to cut costs. That's the deal with private equity. So maybe they're not going to use the highest end medical supplies. Maybe there'll be time limits. Maybe I have a time limit.
Yeah, and what will happen? They'll do something you know, as you say, to cut the corner, possibly do something, and then all of a sudden the government has to get back involved and come up with more restrictions, which is unfortunate, rather than just trying to watch out for it. So we're almost on time, so I have you just one quick question for you. What's going on with COVID? Is it affecting this industry? Other than vaccines and people sick in healthcare, as it relates to valuations.
Right. I would say the majority of practices, surgery centers, especially urgent care centers, have come back from COVID. The volume is almost all up. Some of the urgent care centers, and I'm valuing some, are blowing out of the water what they were doing. They're so busy. They've never been this busy. So they're busier because of all the testing. I mean, it's been huge. And if COVID is here to stay, or it's modifies some, these businesses aren't necessarily going back to what they were doing.
Right.
So it's really business, you know, it's practice to practice, or what type of entity. I think a lot of ERs have slowed down. A lot of emergency rooms, because that business now has been moved to walk to urgent care centers. People are afraid to go to hospitals. So I think there are different sectors that have been affected. And the biggest thing as a person doing valuation is a forecast into the future. And what are the expected cash flows? And I'm doing an urgent care center right now that knows that their cash flows are very high right now, but they're not going to stay here. So we're doing a multi-year model where we show the anticipated decline to a normal state. So I don't think we can generalize, is my main point here, but it is certainly a huge factor, COVID, and something we have to think about in our valuations.
That's great. Okay, Monica, we're past the 15-minute mark, so I want to thank you for all this information, and there's a lot more. I know there is, and that's the point of these sessions, is just to introduce the topic. You know, doctors, medical practices should look into what you're doing and talk with you more about this. This is a different time, so really they need to start focusing on it. Some of the older people are starting to say, you know, I don't want to go through this anymore, and they're starting to look to get out. But start planning ahead, start getting in, you know, things in place now.
That's right.
So I want to thank you for the presentation. I want to thank everybody for watching. Look on our website for any other presentations. Monica, I know we'll be doing a presentation in April on business valuations, and we hope to see you there. So, Monica, thank you very much again.
Thank you, Brad. Thanks so much.